Out east is where we start tonight, where a woman in need of medical attention tried 3 times to get help, only to come up empty. CTV's Atlantic Bureau Chief Kristen Ashkute reports.
Ended up in bed, couldn't stand up.
For 36 hours, Liz LeClaire suffered through excruciating abdominal pain and vomiting in her Dartmouth home.
My signs and symptoms were symptomatic of possibly a bowel obstruction of some kind.
She called the virtual health line and was told it would be 9 hours before she could speak to a nurse. She called 911 and waited more than 2 hours for an ambulance. None arrived. She was told the wait to see an ER doctor was up to 16 hours. So she did the only thing she could, praying her symptoms would subside.
This is the first time I ever thought I might die at home.
This doctor says primary care investments need to happen now, or the situation will only get worse.
We don't have enough doctors or nurses to be able to take care of all the Nova Scotians and Canadians that need access to care.
Across the country, the story is repeated. Doctors and nurses saying they can't keep up with the demand.
I would say that nurses are exhausted, they're burnt out, they're demoralized.
In BC, burnout, low pay, and mental health challenges are the reasons fewer ambulances are on the road. In some parts, there aren't any.
It's happening every day of the week. It's not just isolated to weekends and nights. And that's really putting a strain on the system and affecting our patients.
In northern Manitoba, at the hospital in Lynn Lake, at least 8 patients have been transferred more than 8 hours away to Flin Flon because of staffing shortages forcing the closure of all long-term care beds.
Dr. Michael Warner, ICU physician at Michael Garron Hospital. Dr. Warner, thanks a lot for coming on to CTV News Channel. You're keeping a close eye. What you heard from Sylvia Jones there and her reference to innovation, what is your take?
Well, I think she was clear in that patients won't be paying out of pocket for medical services. And I think it's important that she state that. But when we talk about privatization of the public healthcare system, in my view, it has and continues to occur. And my focus is really on the nursing staffing crisis. We have private companies today that are charging hospitals very high fees to provide them with registered nurses at the bedside. In fact, those fees, which averaged about $65 pre-pandemic, are now up to $110 plus HST post-pandemic, because these companies, which are driven by profit, have taken advantage of the needs that hospitals have in light of COVID and staffing shortages. In fact, Angie, there's one company that charges hospital surge pricing, kind of like Uber or Ticketmaster, whereby if a shift is not booked and it's close to the time that it's to start, the price can go up to $140 an hour. This is not the money the nurse gets, but this is the money the hospital pays, and those dollars are tax dollars. So I don't think that privatization of certain aspects of the healthcare system is appropriate, because it's not improving the staffing shortage, and actually it's costing hospitals more money.
The government has been asked repeatedly what the solution is going to be. They haven't really provided any specifics, but if you needed to see, you know, and you being there on the front line to say, here's what needs to happen, what would you say?
Well, I think if you ask 10 people, you'll get 10 answers, because it's a complex problem. And I would encourage you to ask nurses what would make their life better, because I'm just an ICU doctor. But I think that Bill 124 is a huge sticking point. It makes nurses feel devalued, especially what they've been through over the past 2 or 3 years. That needs to be off the table, because it actually drives nurses towards agency work, where they can earn a higher hourly wage compared to their union wages, because those union wages are depressed, even if we consider vacation pay and benefits. We need to make sure that if we're going to bring on internationally trained and credentialed nurses, that there are people to train them who aren't the same people who are working in the trenches. That means retired nurses or part-time experienced nurses need to be paid appropriately to train these nurses so that they can become active members of the healthcare team expeditiously. Those are the main things that we need to do. But first and foremost, the minister has to acknowledge that there actually is a problem, because she hasn't really done that. In fact, she's deflected and gaslit frontline workers, which makes people on the ground feel like she's not taking the situation seriously. And then, you know, long-term nursing has to be a more appealing profession. It may not just be money. There may be things related to their contract that can be optimized so that nurses aren't driven towards agency work, and so they can enjoy being a full-time employee of the hospital with whatever benefits they feel they need to make that job sustainable.
Dr. Warner, I've got about 20 seconds left here, but I know you're keeping a pulse on this, not just what's happening at a hospital, but overall. What are you watching for now?
I'm concerned that in the fall, if there's a COVID surge, the system will be brought to its knees, because right now there isn't much COVID in the hospital, Angie, and we're experiencing unprecedented problems given this time of year. So I'm hoping the government will act expeditiously, thinking to the future.
Dr. Michael Warner, ICU physician at Michael Garron Hospital. Thank you.